Neurology quiz number 68. What are the clinical features of myotonic dystrophy type 2 or DM2, and how does it differ from myotonic dystrophy type 1 or DM1? DM2 results from an unstable tetranucleotide repeat expansion in the CNBP gene on chromosome 3q21. As in DM1, the repeat expansion sequesters RNA binding proteins, disrupts the splicing mechanism, causing many proteins to be non-functional. This includes the chloride channel, leading to myotonia. Clinical features: inheritance is autosomal dominant. Onset is in adulthood, usually at around age 30, but may occur after age 50. In contrast to DM1, muscle weakness is predominantly proximal rather than distal. It affects primarily neck flexors, hip flexors, and knee extensors. Distal muscle weakness is uncommon even in the late stages. Patients report inability to arise from a squatting position, stand up from a chair, or climb stairs. Prominent atrophy of proximal muscles may occur in some patients. These patients do not have the typical facial appearance of patients with DM1, and ptosis, facial and jaw muscle involvement is uncommon. The presentation is also called proximal myotonic myopathy or PROM. Myotonia is much less prominent than in DM1. Patients rarely report myotonia as a symptom. It can be difficult to detect on physical examination, but may be seen in the proximal muscles. Myotonia is also less frequently detected on EMG than in DM1. Muscle pain is common and severe in DM2 and is described as stiffness or aching. Exercise or cold can worsen the pain. Multi-system manifestations occur as in DM1. These include cataracts before age 50. Patients are at risk for development of diabetes mellitus as in DM1. Both cardiomyopathy with conduction disturbances as well as cognitive and behavioral disturbances, including apathy, avoidant personality, etc., can occur, but they are less frequent and less severe as compared to DM1. Sleep apnea and respiratory abnormalities are seen, but again are less common and less severe as compared to DM1. In DM2, the congenital form is not seen and anticipation does not occur, and there is no correlation between disease severity and repeat length. Diagnosis is made by genetic testing. Muscle biopsies are non-specific and usually not needed. This figure shows a table which summarizes the major differences between DM1 and DM2. Management: patients should have an annual slit lamp examination to screen for cataracts, and symptomatic cataracts should be removed. Patients require regular cardiac monitoring for development of arrhythmias and placement of pacemaker/defibrillator if needed. Patients should also have assessment for sleep apnea, and medications such as modafinil may be useful for fatigue and excessive daytime sleepiness. Patients require screening for diabetes mellitus and thyroid dysfunction. If myotonia interferes with daily activity, mexiletine may be helpful. Other agents that have been used include phenytoin and carbamazepine. Muscle pain may not respond to mexiletine and may require other medications such as gabapentin. Moderate intensity aerobic exercise should be encouraged. Pain and weakness can worsen during pregnancy, and in some patients the symptoms may not return to baseline. Patients with DM1 are at increased risk from general anesthesia. Complications include hypersensitivity to opiates, paradoxical reaction to muscle depolarizing drugs, and prolonged ventilator wean. Though the higher risk is not clearly established for DM2, caution is still recommended.